Okay. So let's start. Please keep in mind 100 questions. It's a lot. We'll solve in the class very slowly, but as we go for exam, we have to keep that in mind. The scenarios are going to be lengthy. They are not going to be very short. They're going to put up a lot of information. So we have to be very clear about the diagnosis. Okay. So let's start. First EMQ is about palliative. So they gave some option about subcutaneous morphine with syringe pump. This is usually given if you want some long action. Movicol is basically given for constipation. This is a laxative. This is again a stimulant laxative, Sena. Then we have hyoscine patch. When do we give hyoscine patch?
And there is localized pain.
Yes,
And there is
localized pain. Yes, when there is a localized hyoscine patch and fentanyl patch. Increased dose of slow release morphine. Maybe we are giving huge amount of medications. We are giving PRN dose or SOS dose, or we can say breakthrough dose are given in higher amount. In spite of that, patient isn't responding. So we'll increase the dose of slow release morphine, decrease the dose of morphine. So let's see, based on the scenario, we are going to choose the actions. Okay. I'll just quickly check if somebody is there in the waiting room. All right. First one, patient with brain tumor, okay, headache, controlled on slow release morphine. See, this is controlled on slow release morphine, BID, and PRN morphine. So slow release morphine, BID means long acting morphine twice plus PRN morphine as per needed. Usually we go with 2 to 4 times. But develop difficulty of swallowing or dysphagia. What to do?
We give it a patch.
Okay. So what happens is that when we treat a patient with morphine, even though it reduces pain, it has some side effects. Remember, morphine reduces everything. So the gut motility reduces, the secretions reduces. Since the secretion reduces, secretions of like everywhere in the body. So the patient finds it difficult to swallow food. So since patient is finding it difficult to swallow food, we are going to give them a localized patch, either fentanyl patch or we are going to give hyoscine patch. So why not, reduce the dose of morphine? Why can't we decrease the dose of morphine?
Yeah, it is controlled.
Yes. So pain is controlled. Not to, that means do not touch. Don't reduce the dose of morphine. In that case, since patient is complaining about localized pain, only treat those particular symptoms. So localized pain treatment, this one will go with the hyoscine patch or fentanyl patch. Do we have fentanyl patch? No, we have hyoscine patch. So we are choosing here hyoscine patch. Okay. So what is the disadvantage of hyoscine patch? The only disadvantage, it's not major. It's actually not good for escalating pain, rapidly escalating pain. If it's a mild to moderate pain, it's well and good. Second thing, hyoscine patches, these patches needed to be changed after every 72 hours. Okay. And what are the good things or what are the advantages? The advantages are that does not have any renal impairment. There is no side effect. It does not cause constipation. Okay. Are we clear with this one? First one?
Yes.
Okay. So this is the first class of solving yearly recalls. I'll try to go a bit slow. If you guys need break, we'll take a break in at 6:30 for prayer. Other than that, if we'll just try to take it slow, okay?
Okay.
Patient with neuroblastoma, so again tumor. Pain is controlled with slow release morphine, BID and PRN morphine. He did not open his bowel for 3 days and he's soiling. What will you give next? So see, you can see almost in case of EMQs, they used to give like that before. Since you guys won't be having EMQs, the scenarios are very similar except for 1 or 2 sentences. So here also they said brain tumor, patient pain is controlled with BID, PRN, morphine. But the only problem is that patient developed constipation. That means did not open his bowel for 3 days. And apart from that, patient is soiling, overflow of the stool or patient is defecating without any kind of awareness. What do you think we should give?
Laxative.
So we have to go with laxative. Initially, we start with Movicol. If patient is, or that is osmotic laxative. If patient does not respond to Movicol, then we can move with other Sena, that is stimulant laxative. Usually we start with Movicol, increase the dose slowly over 7 days. Okay. So most likely this child develop constipation, and due to constipation develop fecal impaction, because soiling is mainly caused due to fecal impaction. Okay, since patient is controlled on morphine, no need to do anything with the morphine, simply add Movicol. In fact, it is suggested that the week you start morphine, the same week itself, it is suggested to start Movicol or any kind of laxative, because it is one of the very known complications, or you can say side effects. Are we clear with this?
Yes.
Okay. Patient with metastatic osteosarcoma on slow release morphine BID and PRN. On reviewing him by palliative care team, they found he received more than 8 doses per day of PRN morphine. PRN morphine means short acting morphine or SOS dose, or we can say these are the small breakthrough doses. But pain is still not controlled. What to do next? What do you think we can do?
Syringe pump, because it's
Increase
taking more
dose.
dose, more PRN.
Yes, so since patient is not improving and we are giving huge amount of this breakthrough dose, we should try to increase the background dose. So actually this one has two answers. You can go for two answer. Either you increase the background dose, increase the slow release morphine, or you can give the morphine by a syringe, subcutaneous morphine by syringe. So slowly it will start releasing throughout the day. Both are convenient. Okay, so we can go with subcutaneous morphine with syringe, or we can increase the dose of long acting morphine or the background dose. Both are correct here. Okay, but this looks more suitable. Actually both are correct, but this looks more suitable, because long acting morphine you are prescribing or you're giving the patient twice a day. But subcutaneous morphine, since it is subcutaneous, so it will be present throughout the day. With syringe, slowly, it will be available throughout the day. So this is looking more accurate. Both are correct, but this is more accurate. Okay. Since RCPCH usually gives number on percentile system, there is usually not 100% correct, 100% wrong answer. Some questions may have two answers as correct answers. Okay. Okay. Next one is.
Sorry, mom, they give the right answer for any one of these both, subcutaneous or increase long
Yes.
acting?
Yes, both are correct, but we are looking for the most accurate one. Like, see,
Yes.
mainly if PRN dose patient is not responding and PRN dose is a high breakthrough dose, the first thing is that we have to increase the long acting dose. So we can do that, but long acting doses are given only twice a day, right? But subcutaneous, what happen if you give through subcutaneous pump, it will be available. These are long acting at the same time available throughout the day. So that's why this is like more accurate. We can go with both. Okay. We can increase the long acting. In that case, what's going to happen? The maintenance dose will be then better for the patient throughout the day. Okay. Next one is hematology. So they gave hereditary spherocytosis, sickle cell disease, iron deficiency anemia, transient erythrocytopenia of childhood, thalassemia minor, thalassemia major, acquired aplastic anemia, hemolysis due to G6PD. First case, Caucasian, very important. Race is extremely important in hematology. Caucasian, 11-month-old baby, fully breastfed. So this is 11-month-old, but baby is fully breastfed. Mother wants to introduce solid food at 12 months, and baby is pale with no other neonatal problems. So tell me, the baby is being breastfed beyond 6 months, right? And baby by 11 months, I mean after the age of 5 to 6 months, baby should be introduced with the solid food, but baby is not introduced with solid food. So this is one thing. Second thing, baby is being fully breastfed till 11 months. So the metabolic demands as well as the demands of the caloric demands of the babies are not met. And if the baby is being breastfed beyond 4 to 6 months, what happens? The commonly baby develops iron deficiency.
Iron deficiency.
And also they mentioned here baby is pale. So this is most likely a case of iron deficiency anemia, because they mentioned that no other problem. So with the given history that baby is not receiving any solid food and being fully breastfed, and mother is planning to breastfeed up to 12 months, and only after 12 months mother is planning to go for solid food. So with this history, this is the case of iron deficiency anemia due to breastfeeding or not introducing a complementary feeding to the baby. Is this clear? So why
Yes.
are we not considering any hemolytic disease?
Child does not have any other
There is no neonatal
symptom.
history or like this.
No
Okay.
neonatal problem.
So there is no neonatal problem. See, this is 11-month-old. Usually hemolytic disorders after they present around after the age of 6 months, okay, 4 to 6 months. They'll present with organomegaly as well. Jaundice, organomegaly. Hemolytic, no? Lytic, if hemolysis is blood lysis is going on, so there will be anemia. Along with that, jaundice will be there. Along with that, organomegaly. So no other features, no organomegaly, no jaundice, nothing of that sort is mentioned. Because by this age, by 11-month-old, if it's hemolytic disease, the child will have episode of such. Plus, as you mentioned, you are also right, there were no neonatal problems. Okay. Next one, Caucasian, 10-year-old boy. On examination, he is pale, he is jaundiced. Pale means anemia, jaundice. So if pale, jaundice, anemia comes together, it is commonly due to, you have to understand, if jaundice and anemia together, it's due to hemolysis. RBC is going through lysis. Okay. Spleen is palpable 2 centimeter below the costal margin. Usually the spleen is only palpable if it is double its size. So if they are saying spleen is palpable, means there is significant splenomegaly. Okay. Hemoglobin is 97. This is a 10-year-old boy. His hemoglobin should be at least above 110 milligram, 110 milligram. Platelet 140, which is 140 into 10 raised to 9 actually. That means 1,40,000. This is towards a lower limit, but all right. WBC is within normal. Reticulocytes is increased. Normal reticulocytes is up to 2%. There is a history of traveling to Greece, not Grace, and he is treated in neonatal period with phototherapy for 2 days. So now let me just mark the most important points. This is a Caucasian child who is 10-year-old, comes to you with anemia, jaundice, and splenomegaly. On investigation, we see hemoglobin is low, platelet are nearly normal, WBC normal, reticulocytes increased, and there is a history of phototherapy in neonatal life. What do we think? Anemia, jaundice?
Hereditary spherocytosis.
Okay. So hereditary spherocytosis, you're correct. Why? See, anemia, jaundice together present, that's case of hemolytic disorder. Okay. Second thing is that only splenomegaly is there. And how anemia, this is proved by this hemoglobin level. Okay. And then what about splenomegaly? There is only one condition. There is one hemolytic disorder where there is splenomegaly. Otherwise, almost in all conditions, there is hepatosplenomegaly. So Caucasian child, Caucasian is important. So every Caucasian child with splenomegaly is, always hereditary spherocytosis unless otherwise proved. It could be a treated case. So in a treated case, what happens is that mostly you don't get the jaundice and anemia. So any Caucasian child with splenomegaly and plus a positive neonatal history of jaundice, you have to consider a hereditary spherocytosis. Here we have so many points in favor. Caucasian, hemolysis features, hemoglobin is low, splenomegaly, neonatal history of phototherapy. 5 points in favor. So this is a case of hereditary spherocytosis. Okay. So what is the pattern of inheritance of hereditary spherocytosis?
Autosomal dominant.
Yes, it is autosomal dominant. In that case, we'll find some family history of similar kind, especially family history of gallstone. Okay. Another thing is, so if we are considering hereditary spherocytosis, what is the investigation that we'll do?
Osmotic fragility test.
Osmotic fragility test. So when we study one condition, it's always important when you're studying by yourself, try to remember and correlate what could be the investigation, what is the treatment, like that, basic things. So for example, iron deficiency anemia, what will be the investigation? Obviously, you're going to look into the hemoglobin level plus iron profile. Okay. For hereditary spherocytosis, obviously we'll go with CBC with peripheral blood film. Along with that, the specific is osmotic fragility test. Okay. Next one. 2 years.
Madam, sorry, Madam, in the options, if there's both blood film, complete blood picture, blood film, plus osmotic fragility, what do we choose?
We'll choose osmotic fragility. because spherocytes, we are thinking spherocytes are there in many conditions. Spherocytes will be there in hereditary spherocytosis. Spherocytes can be there in case of ABO incompatibility. Spherocytes can be there in case of any case of hemolysis, because when excessive level of hemolysis is going on, so the body will try to compensate by reproducing huge amount of RBC. So in very less time, they're producing huge amount of RBC. So usually they're biconcave shape, right? So it's like cooking. It is supposed to be biconcave, but they have very less time. So somehow they are producing this spherical shape. It's not getting into biconcave shape. Also, there is deficiency of folic acid, which leads to this spherical shape. DNA is not matured. Okay. So if they ask for only one, then it is osmotic fragility. That is absolute.
And excuse me,
Yes.
sorry for interruption, ma'am. Is malaria is another condition regardless of the clinical features? The splenomegaly will occur. Malaria.
Yes, we can consider this in case, but then see Caucasian child. Actually,
No,
if they
no,
mention,
ma'am, sorry, excuse me, sorry. I'm not considered for this MCQs because this is Caucasian baby, na? This is not an Asian baby or African baby. So I just want to ask this anemic plus splenomegaly. Is malaria also? We will consider malaria also.
100%, you have to consider malaria. But then what happens is that you are right, you are not considering this. So in our, first of all, in the options, no, it's not there. And second thing, in exam, commonly they'll give you some history of two things. Like if you have to consider malaria in exam, I know you're not talking about this one, you're talking in general. In malaria, we have jaundice, we have anemia, we have fever. For very long time, we have splenomegaly. So in exam, they usually don't give this kind of scenario. If at all they give one special history. History of traveling to South Asia or history of traveling to African countries.
Yes.
So by this, we can pick up. Otherwise, you are absolutely right. These two things are obviously there. Even for clinical exam, depending on which center you're going for, say if you're going for a South Asian center and you have a child with, say, anemia, you have a child with splenomegaly, you will have to say malaria. Without that, they won't pass you. So depending on scenarios, depending on what region they're giving us, we have to select.
Ma'am, in UAE, there is a malaria in UAE.
I have not heard of yet. Malaria is not
Okay.
very common. But I think recently, right, in I think around May, June, there was a flood here in UAE. Then I did see a lot of, I heard about a lot of dengue cases, and there were some malarial cases. One of the
Thank you so
doctors
much.
told me. Otherwise,
Thank you
it's
so
not
much.
common.
Thank you, may Allah bless you.
Okay. Next one, Indian girl presented with history of upper respiratory tract infection. On examination, there is solitary small lymph nodes, and she is pale. So pallor is there with microcytic hypochromic anemia, and reticulocytes are normal. Ferritin is normal. What do you think is the diagnosis? Girl is coming to us with history of upper respiratory tract infection. Now at this time, she is presenting to us with pale. She is pallor. There is pallor, microcytic hypochromic anemia, along with that solitary small lymph node or shorty lymph nodes, which could be due to reactive. So due to this upper respiratory tract infection, 2-year-old girl, she could have this solitary small lymph nodes as a form of reactive lymphadenitis. We don't have the size of the lymph nodes mentioned here. Otherwise, for cervical lymph node, if it is, I think, more than 1.5 to 2 centimeter, we consider it significant. Otherwise, this is most likely a case of reactive lymphadenitis. This is one part, okay? Reactive lymphadenitis. Second part, they are saying, do you think reactive lymphadenitis causes pallor and microcytic hypochromic anemia?
No.
Not at all. Okay, so they gave one part. That's correct. It's not distraction. They did give one part. Okay. Second thing, they are saying child is pale. So there is microcytic hypochromic anemia, but reticulocytes is normal. What is meant by reticulocytes normal? This means if reticulocytes are normal, that means no hemolysis. It's not a hemolytic disorder. Ferritin is normal. If they say ferritin is normal, that means it is not a case of iron deficiency anemia. So what do you think?
In the options, Madam, thalassemia minor. In the
See
options.
the options. Yes, absolutely right. See this. In the options, we have thalassemia minor. So thalassemia minor usually presents with this kind of picture. The child will be well and good. There is usually no organomegaly. Hemoglobin level could be slightly reduced, but not significantly. And you will find microcytic hypochromic anemia. Whenever we have microcytic hypochromic anemia, we have to keep some differentials in our mind. Okay. First one, iron deficiency anemia. Second one, thalassemia. Third one, sickle cell anemia. So is it iron deficiency anemia? No, because iron profile ferritin is normal. Is it sickle cell anemia? Because no, because they did not mention anything about, the child does not have any sickling features or any, what do you say? There are usually some significant features associated with fever, dactylitis, along with hepatosplenomegaly. So we cannot say it is sickle cell. What about thalassemia? Now, there are two types of thalassemia. In thalassemia major, what happens? The child will have some dysmorphic facial features, right? There is usually maxillary hypoplasia. Along with that, the child will have organomegaly. So this child does not have organomegaly. Thalassemia major is out or excluded. What about thalassemia minor? Yes, this could be a case of thalassemia minor with reactive lymphadenitis because child is pale with microcytic hypochromic anemia. So usually the hemoglobin is not significantly reduced, and here the child is well, growth is well, and no organomegaly. That's the diagnosis of thalassemia minor, or we can say thalassemia trait. See here also they have made some small note. In case of thalassemia trait, there is usually ferritin is normal and there is usually no organomegaly. In case of thalassemia major, they'll have severe anemia. So the hemoglobin level would be mentioned along with obvious physical features. Along with that, there would be organomegaly, 100% organomegaly. Okay. That's why this is a case of thalassemia minor. Whenever they...
Also, sorry, also the hint of Indian.
Yes. This is just
for
now I was
thalassemia.
going to say, absolutely. So also this race is extremely important. When they say African, remember most likely, not 100% always, but remember this is how the pattern we have observed. If they say African, sickle cell anemia. If they say Asian, okay, it's a case of thalassemia. If they say Caucasian, hereditary spherocytosis. Race in case of hematology and age in case of musculoskeletal and GIT. Very, very important for diagnosis. Are we clear with this?
Yes.
Okay, let's move. Next one is about headache. Okay. So what happens in case of headache? They gave some option. We have brainstem glioma. Brainstem glioma is basically an infratentorial tumor with cerebellar symptoms or cerebellar tumor. Migraine, we have headache with an aura, occipital headache, there is tension headache, like band-like headache, labyrinthitis. What happens in labyrinthitis?
Vertigo.
Usually there is vertigo, there is dizziness. Along with that, there can be headache as well. Okay, now let's see what happens. First scenario, they gave a female entering secondary school. So entering secondary school means she is in 6th standard, right? She is probably 11 or 12-year-old. Entering secondary school, presented with increasing morning headache and vomiting. Morning headache and vomiting, along with that, ataxia. So we know morning headache and vomiting, these are absolute features of brain tumor. But which brain tumor? So they're making it a bit more specific by saying ataxia. Ataxia means cerebellar tumor involving the cerebellum or the brainstem. Okay, infratentorial tumor, below the tentorium. Below tentorium, they usually come with ataxia. So in the options, if they give cerebellar tumor or infratentorial tumor, you can select that as well. Any infratentorial tumor would present with these features. Along with that, other features of infratentorial, very common brainstem glioma is involvement of the eye, that is recent onset of squint, diplopia, or any kind of other cranial nerve abnormality. Okay, so morning headache along with vomiting, along with ataxia, which is a cerebellar feature. This is a case of brain tumor. The only brain tumor option we have is brainstem glioma. Or what are the other options we could keep in mind? Infratemporal
Temporal tumor.
or cerebellar tumor. Okay.
Okay.
Also remember, commonly they are associated with squint, they are associated with diplopia, all these features. Next one. This is a very, very interesting topic. Just today I was studying about this particular topic and somehow happened to solve this. So female entering secondary school presented with headache. Okay, what is this? Female entering secondary school presented with headache associated with abdominal pain and vomiting. Headache associated with abdominal pain and vomiting. So during the headache or during the abdominal pain, the patient will come to us with vomiting. Patient may come to us with photophobia. They may come to us very common pallor. Okay, this is a case of abdominal migraine. Okay, this is diagnosis of exclusion. Usually there are two types of abdominal pain which we make as diagnosis of exclusion. One is abdominal migraine, second one is functional abdominal pain.
Functional abdominal pain.
So if we only exclude other organic causes, only then we can diagnose this as a case of functional abdominal pain or abdominal migraine. So why I'm telling it is abdominal migraine? Abdominal migraine usually comes with intense episodes of pain, usually lasting for 1 hour. During the pain, the child may have photophobia, the child may have headache, vomiting. Vomiting is extremely common. Pallor on the face. Okay, they'll say usually she's not pale, but she just develops pallor during the pain. And she is usually pain-free in between the episodes. So first point, the child will have intense pain occasionally. And during the pain, she turns pale. There are no interval symptoms. In between the pain, she is absolutely fine. The third thing is that there is no organic cause. So they could have done investigation. There is no fever associated with it. There is no irregular bowel movement associated with. There is no failure to thrive with it. Nothing of that sort. This is a diagnosis of exclusion, and this is known as a case of abdominal migraine. Okay, so we don't have a lot of options here, but this is the only option. This is a GIT portion, but they just put the headache along with this. Okay. There is usually associated with a family history. So you might also want to ask about, or in exam, you might also see that there was a similar history of such illness in the family. Are we clear with abdominal migraine?
Yes, yeah.
Next one. Female entering secondary school presented with diffuse banding headache with no vomiting. So band-like headache is a feature of tension headache with no vomiting. No vomiting means what are they trying to exclude?
Cluster.
Tumor.
Tumor, absolutely
Tumor.
correct. Brain tumor, usually brain tumor associated with vomiting. Headache with vomiting, you have to be very conscious. Okay, so this is a case of tension headache. Are we clear? See, the options are given.
Ma'am, excuse me.
Yes, yes.
I'm sorry for interruption. Ma'am, is there a cluster headache occurs in pediatric population, ma'am?
Cluster headache is less common in pediatric population, but then it is possible because here actually we are dealing with theory. Okay, we are dealing with theoretical questions. So if you tell me that whether this is possible, it is possible, but very rare cases. Again, see,
Okay.
abdominal migraine. If I'm considering a theory only based on this, I can, if this particular history comes to me in my clinic or say in my hospital, I'll never diagnose this as a case of abdominal migraine with this history. I'll have to exclude everything first and then go for the diagnosis of exclusion. So theoretically, a lot of things we are studying here, maybe they are not common in real life. Okay.
Thank you so much. May Allah bless you.
Next one, puberty. This is a very, very important question. I think last time also they told me a lot of questions came from puberty. Puberty we have studied in endocrine system. If you don't remember, it is one topic which is sometimes a bit difficult. Okay, so let's see. So they have normal puberty, premature adrenarche. Premature adrenarche is a feature of precocious puberty, correct? But in case of premature adrenarche, there will be features of increased testosterone. What are those? axillary hair, pubic hair, adult type of body hair, and then increase in the height, blood pressure, etc. These are premature adrenarche features, means increase adrenal androgen features. Central precocious puberty. What is the central sign of puberty in a girl?
Menstruation.
Menstruation.
Can you please repeat?
Menstruation.
Menstruation in a girl. What about
No,
in a boy?
Testicular enlargement.
Testicular
Enlargement.
Testicular
Testicular
enlargement.
enlargement.
Testicular. Yes, absolutely. The central sign of puberty in a boy, testicular enlargement. Also, it is the first sign of puberty in a boy. And then the central sign of puberty in a girl is menstruation or menarche. Okay. Now we have, what about congenital adrenal hyperplasia? Congenital adrenal hyperplasia usually in older children. I'm not talking about neonates. In older children, especially in case of boys, they can present to us with precocious puberty. Because in congenital adrenal hyperplasia, that is the most frequent form. I'm talking about 21 hydroxylase deficiency. Usually there will be increased testosterone level. So due to increased testosterone, they can present to us with precocious puberty. But will that be central or peripheral?
Peripheral.
Peripheral, because increased testosterone, increased estrogen associated with peripheral precocious puberty, or we can say non-gonadotropic or non-gonadotropin independent. Okay, or gonadotropin independent precocious puberty. If follicle stimulating luteinizing hormone is increased, then we call it central precocious puberty or gonadotropin dependent precocious puberty. Okay. Klinefelter syndrome, we studied usually tall stature, delayed puberty. Along with that, the child will have gynecomastia. In case of Prader-Willi syndrome, PWS, here what happens? The child usually develops hypotonia, poor feeding, followed by obesity, hyperphagia, and there is usually hypogonadism, learning difficulty in the child. Okay. Then adrenal tumor. So adrenal tumor means all the adrenal hormones will increase, be it testosterone, be it the other adrenal hormone. So if testosterone is increasing, that means they will produce the symptoms of premature adrenarche, isn't it? Because in premature adrenarche, what is the pathology? Premature adrenarche means excessive adrenal androgen. Excessive adrenal androgen can come from adrenal tumor. Okay, peripheral. McCune-Albright syndrome. McCune-Albright syndrome, usually it is a syndromic disorder. What happens in McCune-Albright? There is cafe au lait spot with coast of mean appearance. Along with that, there is fibro-ostotic dysplasia. That is usually child will come with history of fracture plus precocious puberty. Features of precocious puberty. Craniopharyngioma. Craniopharyngioma again is associated with precocious puberty. So if it is craniopharyngioma, this is a brain tumor. This will be central or peripheral precocious puberty?
Central.
Central, 100%. Okay. Now let's go. This topic is a bit complicated. So today you might want to go and revise the puberty topic. Just forward a little bit. Okay. Next one. 11-year-old girl. So 11-year-old, look at the age, girl, presented with menarche. So menstruation. She started with breast and pubic hair before two years ago. Height is on the 91st centile. So she is now 11-year-old and she has menstruation. Okay, so she is 11-year-old, she has menstruation. When she was about 9-year-old, that is from 2 years ago, she had breast bud development and pubic hair development. Is this normal?
Yes, it is normal.
Absolutely. See, at 11 years, she is having menstruation, and the age of puberty in case of a girl is 8 years, from 8 years. So if she started, they are saying from 8 years onwards, if she started her breast development, which is the first sign in case of girl, and pubic hair 2 years ago, that means around 9 years, that means initially it is absolutely going in order. There was breast development, pubic hair, axillary hair. Now at 11 years, she's developing menstruation. So this is absolutely a case of normal puberty. Does anyone have any, different opinion about why this is normal, why it's not abnormal?
Normal.
Okay, great. So this is the case of, even we have the option as well, normal puberty. Okay. One important thing I always say is that look into the options. While practicing, you don't look. It's okay. While practicing, after making your diagnosis, then you look into the option. In the exam, always look into the options. In that way, you will have only few differentials in your mind. It will be easy for you, cut down the time, stressing time for you. Okay. Next one, 6-year-old girl. 6-year-old girl came with scanty pigmented pubic hair and acne. Now, 6-year-old, the age of puberty in a girl is from 8 years. This is 6-year-old. Is this precocious or not?
Yes.
This is a case of precocious puberty. But what kind of precocious? Does she have menstruation? No. So we cannot say this is a case of central precocious puberty. But she has pigmented and slightly pigmented pubic hair and acne. So what are the signs?
From
Pubic-
adrenal.
Yes. So pubic hair acne, these are caused due to adrenal androgen, excessive adrenal androgen. So this is a case of precocious puberty. But what kind of precocious puberty? Premature adrenarche. Okay. So this is a case of premature adrenarche, or we can say this is a case of adrenal tumor. Because adrenal tumor will again lead to premature adrenarche. But it's not very, what do you say? This is not a very aggressive scenario that they have provided. In case of, if it is a case of adrenal tumor, it's a possibility. It could be the initial state of adrenal tumor, where the cortisol, aldosterone, and testosterone, everything is rising. The child will have increased blood pressure, increase in the height due to the effect of the testosterone. There will be features of pubic hair, axillary hair, acne, adult type of body hair. This could be as well. But usually the signs are very prominent and very aggressive in case of adrenal tumor. Both are possible here. So this is a case of precocious puberty caused due to adrenal tumor, or we can say this is the case of premature adrenarche. Since the scenario looks very mild, we can say this is a case of premature adrenarche. Both are correct.
Sorry, I just wanted to ask, what if there's menstruation at this age?
If she has menstruation at this age, that means
Yeah.
that will be central precocious puberty.
Okay.
That means
Thank
maybe due to brain tumor or some other features. Usually in girls, central precocious puberty could be idiopathic or could be familial. It is less likely to be, pathological unless they provide any features of brain tumor. But in case of boys, precocious puberty is always pathological. Okay, since it's a girl and absence of menstruation, so this is not a case of, this is not a central sign. So not a case of central precocious puberty. I know this topic is a bit difficult, and I'll suggest you please today or tomorrow morning go and revise the puberty portion. Not everything from endocrine, only the puberty portion. Okay, is this clear?
Yes, thank you.
So this is a case of, we can say, precocious puberty, but specifically premature adrenarche. Okay. Next,